Dual chamber pacing. In DDD mode, both AV and VA intervals dictate the device response to the native rhythm. AV is the interval from the paced or sensed atrial event to the next ventricular pacing. VA is the interval from the paced or sensed ventricular event to the next atrial pacing. DDD operation mode. Atrial pacing occurs if no native atrial activity for set time, that is, the VA interval, following ventricular activity. On the other hand, if a native atrial activity is sensed during the VA interval, the atrial channel is inhibited, VA interval is interrupted, and an AV interval is started. Ventricular pacing occurs if no native ventricular activity for set time, that is, the AV interval, following atrial activity. On the other hand, if a native ventricular activity is sensed during the AV interval, the ventricular channel is inhibited, AV interval is interrupted, and an VA interval is started. Atrial event. AV interval is activated. If no intrinsic ventricular activity during AV interval, ventricular pacing is delivered. Ventricular event. VA interval is activated. If no intrinsic atrial activity during VA interval, atrial pacing is delivered. Based on previous discussions, these conclusions can now be made. Following an atrial event, paced or sensed. In AAI pacemakers, the atrial channel is inhibited, a new AA interval starts, and the impulse is conducted to the ventricles in the AV node. In a dual-chamber pacemaker, the atrial channel is also inhibited, and the time clock starts a new AV interval, during which, if a native ventricular activity is sensed, ventricular channel is inhibited, AV interval is interrupted, and an VA interval is started. On the other hand, if no native ventricular activity is sensed during the AV interval, ventricular pacing occurs, and an VA interval also starts. Following a ventricular event, paced or sensed. In VVI pacemakers, the ventricular channel is inhibited, and a new VV interval starts. In a dual-chamber pacemaker, the ventricular channel is also inhibited, and the time clock starts a new VA interval, during which, if a native atrial activity is sensed, atrial channel is inhibited, VA interval is interrupted, and an AV interval starts. On the other hand, if no native atrial activity is sensed during the VA interval, atrial pacing is delivered, and an AV interval also starts. The device algorithm inhibits the atrial channel when this channel senses a native atrial event, a normal function, or sometimes, an inappropriate signal, oversensing. The device algorithm inhibits the ventricular channel when this channel senses a native ventricular event, a normal function, or sometimes, an inappropriate signal, oversensing. The DDD timing events, including the blanking intervals and the refractory periods, as well as inhibition and triggering, pacing, of the atrial and ventricular channels, are really complicated, but it is time to discuss in detail. DDD timing events. After an atrial event. In atrial channel, atrial refractory period, ARP, starting with atrial blanking interval, ABI. In ventricular channel, sequentially. AV interval, AV, is activated. Post-atrial ventricular refractory period starting with a blanking interval. Ventricular safety window. Either sensing and inhibition of the ventricular channel, or ventricular pacing. After a ventricular event. In ventricular channel, ventricular refractory period, VRP, starting with ventricular blanking interval, VBI. In atrial channel, VA interval, VI, is activated. Post-ventricular atrial refractory period, PVARP, starting with atrial blanking interval. Either sensing and inhibition of the atrial channel, or atrial pacing. Upper rate interval, upper tracking rate. Lower rate interval, pacing rate. Atrioventricular interval, AV. The AVL corresponds to the PR interval of the surface ECG. It is measured from the atrial pacing spike or the start of a sensed P wave, to the ventricular pacing spike or the start of a sensed QRS complex. The AV is named after the atrial event. In case of a paced atrial event, the AV is called a paced-AV interval, PAV. In case of a sensed atrial event, the AV is called a sensed AV interval, SAV. During the whole PAV or SAV, the atrial channel is refractory, that is, the whole AV interval is an atrial refractory period, ARP, which starts with a blanking interval. DDD pacing. First 2 beats, 1 and 2, show atrial and ventricular pacing. Atrial pacing occurs because no sensed atrial events before expiry of VA interval, and ventricular pacing occurs because no sensed ventricular events before expiry of AV interval. In the next 2 beats, 3 and 4, native P waves are sensed, no atrial pacing, but only ventricular pacing is seen. It is to be noted that atrial sensing occurs after the start of P wave by the time needed for the P wave to conduct to the atrial electrode. This explains why sensed AV interval, SAV, is programmed at a value lower than paced AV interval, PAV, to obtain equivalent PR intervals. Changes in the ventricular channel after atrial events. Post-atrial ventricular blanking interval, usually 30 ms. The ventricular channel is blanked, to avoid sensing of atrial events. Obviously, ventricular events will not also be sensed. Ventricular safety window, this interval starts after the blanking period. During this time window, any sensed event, whether ventricular, atrial, or artifacts, triggers ventricular safety pacing at the end of this safety window, so that ventricular asystole is avoided. In case a ventricular premature beat occurs during this window, the pacing impulse is delivered during the premature beat refractory period, and will not capture the ventricles. After the safety window, a sensed ventricular event during the AV interval will inhibit the ventricular channel. If the AV interval expires without a sensed ventricular event, ventricular pacing occurs. After paced or sensed atrial events. In atrial channel, atrial blanking interval, ABI, and atrial refractory period, ARP, start. In ventricular channel, AV interval is activated. The AV interval is the same as the ARP, and the ECG-PR interval. Post-atrial ventricular refractory period, PAVRP, starting with a blanking interval, BI, are also activated, followed by safety window, SW, and finally the sensing period, to allow a sensed event inhibit ventricular channel, or otherwise ventricular pacing is delivered. After ventricular events. In the ventricular channel, ventricular refractory period, VRP, starts, during which the ventricular channel is refractory. It starts with a blanking interval, as usual. Following this period, sensing with inhibition recurs. In the atrial channel, post-ventricular atrial refractory period, PVARP, during which the atrial channel is refractory. It starts with a blanking period, followed by the VA escape interval, in which atrial sensing is allowed. If there is no sensed atrial event, atrial pacing is delivered. After paced or sensed ventricular events. In the ventricular channel, ventricular refractory period, VRP, starting with a blanking interval, VBI, is activated, followed by sensing with inhibition. In the atrial channel, post-ventricular atrial refractory period, PVARP, starting with a blanking interval, PVB, followed by atrial sensing to allow an atrial event to inhibit the atrial channel, otherwise, atrial pacing is delivered. It is of particular importance to notice that the atrial channel is refractory all through from the start of an atrial event and almost to the end of the T wave. This period is called the total atrial refractory period, TARP, which is composed of 2 successive periods. 1. Atrial blanking and refractory periods, following an atrial event, whether paced or native, followed immediately by 2. Post-ventricular atrial blanking and refractory periods, following a ventricular event, whether paced or native. The total atrial refractory period, TARP, is composed of 2 successive periods, 1. Atrial refractory periods, ARP, following an atrial event, whether paced or native, and 2. Post-ventricular atrial refractory period, PVARP, following a ventricular event, whether paced or native. This figure clearly demonstrates that, with atrial and ventricular pacing, the lower rate interval can be calculated either as the AV and VA, or AA interval, or VA and AV, or VV interval. Upper and lower rates. Upper rate interval, upper tracking rate. This is the shortest interval, highest rate, at which the pacemaker will pace the ventricle. It is used in dual-chamber pacemakers, which are sensing in the atria. In presence of sinus or supraventricular tachycardia, the pacemaker can track the tachycardia rate and pace the ventricle up to the upper rate only, not faster. That is why it is also called the upper tracking rate. Lower rate interval, this is the longest interval, lowest rate, at which the pacemaker may pace the heart. Upper rate behavior. When the atrial rate exceeds the programmed upper rate limit, the pacemaker will exhibit either Wenckebach or 2:1 AV block behavior. In patients with complete AV block treated with dual-chamber pacing, the pacemaker will exhibit AV sequential pacing, so long as the native rate is slower than the pacing rate. When the native rate exceeds the pacing rate, the device will track the atrial rate and trigger the ventricles, in 1:1 ratio, up to a maximum, the upper rate limit. When the native atrial rate even exceeds the upper rate limit, the pacemaker will shift from 1:1 AV ratio to Wenckebach behavior. The latter will further progress to 2:1 AV activation ratio, when the atrial rate exceeds the rate of the total atrial refractory period, TARP. Explanation of pacemaker Wenckebach behavior. When the patient with complete heart block exercises to a sinus rate beyond the upper rate limit of the pacemaker, the P wave that is sensed is followed by ventricular pacing with gradual prolongation of the AV interval. When one subsequent P wave falls in the post-ventricular atrial refractory period, PVARP, it will not be tracked, resulting in pacemaker Wenckebach behavior. P wave 1 triggers ventricular pacing at the end of AV interval, AV, yellow. P2 initiates a new AV, but when AV expires, upper rate interval, URI, green, has not been satisfied, so AV is prolonged, added red area. When URI is satisfied, ventricular pacing occurs. With P3 and P4, AV extension is greater. These four P waves are tracked and triggered ventricular pacing because each one falls outside the total atrial refractory periods, TARP, of the previous beat. P5 falls within the total atrial refractory period, TARP, of P4, it is sensed but not tracked, did not initiate ventricular pacing, and a pause is created. The cycle is then repeated. This is Wenckebach behavior showing group beating, pauses, and gradual prolongation of PR interval, expressed here as the AV. Pacemaker Wenckebach behavior can progress to 2:1 atrioventricular, AV, activation ratio, when the PP interval becomes shorter than the total atrial refractory period, TARP, then every alternate P2 falls within the post-ventricular atrial refractory period, PVARP. In patients with DDD pacemakers, P waves may be either paced or sensed. QRS complexes may be either paced or sensed. Possible rhythms in patients with normally functioning DDD pacemakers. 4 normal DDD operation modes are well known. 1. Normal sinus rhythm, atrial and ventricular sensing with complete pacemaker inhibition. 2. Atrial sensing, ventricular pacing. 3. Atrial pacing, ventricular sensing. 4. Atrial and ventricular pacing. Atrial sensing, ventricular sensing, normal sinus rhythm as if the patient has no pacemaker, occurs when 1. Sinus rate is faster than programmed pacemaker lower rate, inhibiting atrial pacing, and 2. Native PR interval is shorter than programmed AV interval, allowing AV conduction and native ventricular activation before the end of programmed AV interval, thus also inhibiting ventricular pacing. Atrial sensing, ventricular pacing occurs when 1. Sinus rate is faster than lower rate limit, inhibiting atrial pacing, and 2. Native PR interval is longer than programmed AV interval, or there is no AV conduction. The result is sensing of P waves, inhibition of the atrial channel, and triggering of the ventricular channel after the programmed AV interval. In this situation the ventricle is paced at the sinus rate until the upper rate limit. This mode is also called atrial synchronized or P-wave synchronized ventricular pacing. Atrial pacing ventricular sensing occurs when 1. Sinus rate is slower than programmed pacemaker lower rate, allowing atrial pacing, and 2. Native PR interval is shorter than programmed AV interval, allowing AV conduction and native ventricular activation before the end of programmed AV interval, thus inhibiting ventricular pacing. Atrial and ventricular pacing occurs when 1. Sinus rate is slower than programmed pacemaker lower rate, allowing atrial pacing, and 2. Native PR interval is longer than programmed AV interval, allowing ventricular pacing. In addition to these 4 normal DDD operation modes, some authorities add a 5th normal DDD operation mode, which is the pacemaker response to a premature ventricular complex, PVC, that interrupts the VA interval, conducts retrograde to the atria during the post-ventricular atrial refractory period, PVARP, creating a retrograde P wave. The pacemaker during the PVARP cannot track this PVC, but the PVC initiates a new VA interval, at the end of which atrial pacing occurs. Pacemaker responds to a premature ventricular complex, PVC, that interrupts the VA interval, conducts retrograde to the atria during the PVARP creating a retrograde P wave. The pacemaker during the PVARP cannot track this PVC, but the PVC initiates a new VA interval, at the end of which atrial pacing occurs. On the other hand, if the PVC conducts retrograde after the end of PVARP, the retrograde P wave will be sensed and tracked. In this case, a new AV interval, instead of VA interval, is initiated, followed by ventricular activation, retrograde conduction, ventricular activation, and so on. This repetitive process is similar to the reentry phenomenon. It initiates a special type of tachycardia called pacemaker-mediated tachycardia, PMT, which is of course an abnormal operation mode, to be discussed later with pacemaker malfunction. DDD pacing in patients with sinus node dysfunction. If patients have intact AV conduction, the DDD pacemaker functions as an AAI pacer. Patients with sinus node dysfunction and DDD pacemakers may have fusion beats, from RV pacing plus natural AV conduction. Fusion beats with DDD, the presence and the degree of fusion depend on the difference between the programmed AV interval and the intrinsic AV conduction time. If the conduction time between the sensed or paced atrial complex to the right ventricular lead is shorter than the programmed sensed or paced AV interval, the ventricular output is inhibited. Pseudofusion is said to be present if the pacemaker senses ventricular electrogram late during depolarization, and paces in the middle or towards the end of the QRS complex. The QRS morphology will not be disturbed. Thank you.